Good morning, my name is Jason Hall, and this is the timeline from JJKD. The coroner's report on JJKD outlines autopsy findings, JJKD's mental health history, and the input of mental health services, family concerns, a root cause analysis, and subsequent recommendations made to mental health services. To understand how we can learn from this case, we must first take a look at the timeline of JJKD's care. In 2008, JJKD was a brief client of the acute care team. He had several admissions to the acute adult mental health unit and was misdiagnosed with bipolar affective disorder. He was prescribed sertraline, sodium valproate, and risperidone. Further admissions led to the review of the diagnosis in April 2009, and it was changed to schizoaffective disorder. He was commenced on quetiapine and lithium. His early warning signs were recognized as aggression, often precipitated by medication non-compliance, illicit drug use, and alcohol use. He was placed on an involuntary treatment order under the Mental Health Act. From May 2009 to August 2013, JJKD was managed by the Community Continuing Care Team. An inpatient admission followed due to the deterioration in his mental state, secondary to ongoing cannabis use, non-compliance with medications, and non-attendance to appointments with his psychiatrist. He was recommenced on lithium and olanzapine and transferred back to CCT. Between October 2013 and April 2014, he was case managed by a different team, the Community Mental Health Clinic. Residual mood symptoms, psychotic symptoms, and negative symptoms of schizophrenia prompted a medication change to clozapine. He was admitted between April 7, 2014 to the 1st of May 2014 on an ITO in order to commence clozapine therapy. He was discharged back to CCT on an ITO, and his case manager was Nurse GK. Initially, Nurse GK accompanied JJKD to the clozapine clinic on a weekly basis, but then he independently attended these appointments on a monthly basis. His clozapine levels fluctuated from subtherapeutic to therapeutic, which was attributed to non-compliance, alcohol, and illicit substance use. On the 17th of April 2015, JJKD's community-based ITO was revoked by his consultant from the clozapine clinic. He then continued to attend his appointments voluntarily, although his clozapine levels remained consistently subtherapeutic. During August 2015, it was planned for JJKD to be discharged from CCT and transferred to a GP and private psychiatrist, who was the same as that of the clozapine clinic. Mid-September 2015, he was noted taking 150 milligrams of his 400 milligram dose of clozapine. On the 29th of September, JJKD cut his wrist superficially with a knife. He was subsequently placed on an emergency examination order and taken to hospital. He was not found to be suicidal and was discharged into the care of his mother, and CCT was notified of his presentation. Nurse GK attended JJKD's home after being contacted by his mother with concerns regarding his low mood and reducing clozapine. JJKD was not deemed to be an immediate risk to himself, although presented as paranoid. JJKD was to have an appointment with his private consultant psychiatrist from the clozapine clinic in a week, and a medical review with the community consultant in 3 weeks. JJKD's mother contacted CCT on numerous occasions throughout October. She continued to voice concern of her son's deteriorating mental state, which was increasing paranoia and decline in mood. Documentation from the medical review the following day outlines the impression that JJKD was suffering from depression without psychotic symptoms, ongoing cannabis and alcohol use. The plan was to transfer JJKD's care to the community consultant psychiatrist and to continue to reduce clozapine. He attended medical reviews with both CCT and his private psychiatrist on the 14th and 19th of October 2015, and was advised to gradually cease clozapine by the end of the week and commence aripiprazole. A week later, JJKD phoned Nurse GK to advise that he had not slept for 3 nights, and attributed this to ceasing clozapine and missing 1 to 2 doses of aripiprazole. JJKD was to be reviewed by his community consultant the next week and was advised to attend GP for medication to assist with sleep. The dose of aripiprazole was then titrated at the start of November 2015, although JJKD continued to deteriorate during the month. By the 25th of November, he had self-ceased all medications whilst using cannabis, occasionally drinking, and presented with persecutory delusions. On the 29th of November 2015, an incident occurred at McDonald's which resulted in JJKD becoming verbally abusive, threatening staff and walking behind the front counter and taking food. His mother disclosed this incident to Nurse GK on the 1st of December 2015 during a home visit. JJKD was not sleeping or taking his medication. A medical review was planned for 3 weeks' time. Both JJKD's mother and sister contacted ACT and CCT during December 2015, expressing concern regarding his behaviour, ongoing deteriorating mental state, and increasing drug use, methamphetamine and cannabis. Nurse GK attempted but was unable to contact JJKD. JJKD was reviewed on 23rd of December 2015. He was unmedicated for an unknown period of time and had ongoing positive and negative symptoms, with deterioration in his judgment. He was commenced on a depot injection of aripiprazole, and this was administered. The plan was for weekly case management and for a medical review in 4 to 6 weeks' time. On the 31st of December 2015, JJKD showed a lack of judgment when he went surfing in dangerous conditions and consequently drowned and died. In my opinion, there were numerous flaws in this case which contributed to the adverse event of JJKD's death. Firstly, the fragmented care of JJKD received meant that he was at one point engaging with 3 separate care teams. This was also during the time when he is seen to be displaying warning signs of his deterioration and was also undergoing significant medication changes which requires close supervision. To make matters worse, there was a very slim to no communication between these teams. This led to an inconsistent and confusing approach to his care and medication management. There were many medication changes due to them not being effective despite evidence of non-adherence. A depot injection was not considered until very late in his care. The down titration of his clozapine was poorly managed, and JJKD did not receive the amount of supervision that was required. There was no action when warning signs were occurring. On several instances, JJKD's family escalated their concerns, and warning signs were identified by the multidisciplinary team, but not acted upon. There were inadequate care reviews and an identified 7-month gap where JJKD's care was not discussed by the multidisciplinary team. This case is a learning curve for mental health nurses. There were many instances throughout the case where nursing intervention could have led to a better and safer outcome for JJKD. This includes closer monitoring after significant events, medication changes and warning signs, advocate for the wishes of JJKD and his family, and when concerns are being presented, monitoring medication adherence and asking JJKD about side effects and communicating this back to the care team, care planning with JJKD. This would have enabled JJKD to be a part of his care and determine what he wanted and saw as relevant for his life. Providing education regarding medications, what to expect and be aware of, and the importance of adherence and interactions with substances, as well as a referral to alcohol and other drug services as substances use continued. The nursing interventions are ones that I would take forward in my career and encourage other mental health nurses to do so.